Good evening, everyone. If I'm audible and visible, please send your thumbs up in the chat box. Welcome, Hitesh. Welcome, Smith Christian. Okay, guys. So let's start. Unacademy is launching lots of products for NEET PG. So edge closer to acing your exam preparation, you can get 20% off on all NEET PG Unacademy subscriptions. For 12 months subscription, you have to pay only 18,700. For 9 months, it's 17,000, and for 6 months, it's 15,300. You can subscribe. It is valid till July 15, and you can use my code Dr. Pritesh. For the iconic subscription, what you're going to get, Unacademy Plus Notes 2.0 plus mentoring session. And you can subscribe this also by using my code Dr. Pritesh. NEET PG Vitals. Unacademy is presenting NEET PG Vitals. So here you will be getting recorded lectures for comprehensive NEET PG preparation. Here 800 plus hours of comprehensive recorded classes are there for all 19 subjects. Okay, guys. So let's start. Good evening, everyone. Disha, Ashfaq, Kavita, Hitesh, Naruto. Now, see, guys, this question. 40 years old female felt a mass in her left breast. On examination, mass of 3.33 into 3 centimeter in left breast in upper outer quadrant with single palpable lymph node 2 into 2 centimeter in size on anterior border of axilla on same side. So there is lump in the breast 3 into 3 centimeter left breast, and there is single palpable lymph node. Opposite breast axillary examination is unremarkable. No finding is there. What is the next best step? Tell me, guys. So in this case, patient is having left breast lump in the left breast. So she is having breast lump in the left breast, and there is axillary lymph node. The patient is having axillary lymph node. It's palpable. Clear? So what is the next best step? Tell me, guys. What is the first investigation done in a patient of suspected breast cancer? You know, we go for mammography. And what is the investigation of choice for diagnosis? Investigation of choice for diagnosis, it is biopsy, also known as true cut biopsy, core cut biopsy, needle biopsy. Okay. So humble Dr. Akshit Dua, Dr. Muhammad, Malik, Ashfaq, Kavita, Naruto, Nisi, Neelam, everybody is correct. Clear, guys? So first see, ultrasound guided biopsy of breast mass. Yes, it's done. Ultrasound guided biopsy of lymph node, it is not done. Bilateral mammography is the first investigation done. PET scan, it is not done in this case. PET scan is done whenever we are suspecting metastasis. So what is correct here? 1 and 3. 1 and 3. So correct answer is B. I'm repeating. What is the first investigation done? First investigation done in a suspected case of breast cancer, all of you know, that is what? That is mammography. So first investigation done, that is mammography. And you know, guys, what is the investigation of choice for diagnosis? Investigation of choice for diagnosis of breast cancer, that is biopsy, also known as true cut biopsy, also known as core cut biopsy, true cut biopsy, core cut biopsy, and this is also known as needle biopsy. Needle biopsy. Clear? So here the correct answer is B. Correct answer is B. We are going to perform what? 1 and 3. Mammography and biopsy. Okay. Now read this question, guys, and tell me what is the correct answer. A patient presented with breast lump. On biopsy, it came out to be the breast cancer with ER positive. Estrogen receptor is positive. Tamoxifen was given to the patient. So tell me, tamoxifen increases the risk of which malignancy? Simple question. Tell me, guys. Kamal Khan, Mohit, Akshit Dua, Smith, Parikshit, Rohit Pawar, Riya, Kavita, Humble Doctor, Kamal Khan, Malik, Hitesh, Dua, Neelam, Nisi, Kamlesh, Ashfaq, Gungo, Naruto. Clear? Everybody is correct, guys. Everybody. So what happens? You know that this tamoxifen, it is having agonistic effect. It is having agonistic effect on endometrial cells. So on endometrium, there is agonistic effect. Because of this, what happens? It is going to increase the risk of endometrial cancer. It is going to increase the risk of endometrial cancer. And that's why you know that in premenopausal females only we are giving tamoxifen. So drug of choice for hormone therapy in premenopausal females, that is tamoxifen. In postmenopausal females, it is aromatase inhibitor. Why? Because in postmenopausal females, there is increased risk of endometrial cancer. That's why we avoid tamoxifen. So tamoxifen increases the risk of endometrial cancer. It increases the risk of endometrial cancer. Very good. Tamoxifen, there is another agent which is selective estrogen receptor modulator, raloxifene. And what are the aromatase inhibitors we give? Letrozole and estradiol. Clear, guys? Next question. Tell me, very, very easy question. 35 years old, pregnant female with hyperthyroidism. Which anti-thyroid drug should be given in first trimester? Let me see who is going to reply this question correctly. In the first trimester, which anti-thyroid drug? Karina, Naruto, Ankit, Niksha, Nirmala, Hitesh, Humble Doctor, Mehak, Akshit, Gungo, Kamlesh, Dua, Disha, Kamal Khan, Ashfaq Ansari, Rohit, Neelam. Everybody is correct. Guys, see. What are the anti-thyroid drugs we give? Methimazole, carbimazole, propyl thiouracil. So you know that this methimazole, it's the anti-thyroid drug of choice. This is anti-thyroid drug of choice in Graves' disease. In Graves' disease. Clear? What is the anti-thyroid drug of choice in pregnancy? If nothing is mentioned, trimester is not mentioned, in pregnancy we give carbimazole. In pregnancy we give carbimazole, or in the question it is mentioned second or third trimester. In second or third trimester we give what? Carbimazole. Propyl thiouracil increases the risk of hepatic failure in females and children. That's why we should not use propyl thiouracil until and unless there is emergency. And you must be knowing what is that emergency, guys. Tell me in the comment box. What is that emergency? Yes, propyl thiouracil, thyrotoxic crisis. This is used in thyrotoxic crisis. So why we are using it in thyrotoxic crisis? Because you know it blocks peripheral conversion of T4 to T3. Apart from thyrotoxic crisis, we can use it in pregnancy, especially in which trimester? So pregnancy in first trimester. Pregnancy in first trimester. So if the question is asked, anti-thyroid drug of choice in pregnancy, carbimazole, first trimester propyl thiouracil, second and third trimester carbimazole, and in Graves' disease, which one we give? We give methimazole. What is the role of Lugol's iodine? You know that it decreases the vascularity. So it decreases the vascularity, decreases the bleeding intraoperatively. So it decreases the vascularity of thyroid, decreases intraoperative bleeding. Clear, guys? Okay. Next question, easy question, guys. Tell me what is the correct answer here. Papillary carcinoma. Histopathology slides shows what? Histopathology slide shows orphan NEI nuclei. It shows orphan NEI nuclei. All of the following are correct about this condition except. Tell me, guys, what is the correct answer? Naruto, Akshit, Disha, Dua, Humble, Azhar Shah, Mohit, Ria, Navrang, Malik, Navrang, Karina, Neelam. Clear? So everybody is correct, guys. This is papillary carcinoma thyroid. And you know that in papillary carcinoma thyroid, what is the most common route of spread? The most common route of spread is lymphatic. There is specific nuclear pattern on histology. And what is that specific pattern? Orphan NEI nuclei. out of papillary, follicular, medullary, anaplastic. This one is having best prognosis. And you know what is the investigation of choice for diagnosis? Investigation of choice for diagnosis for most of thyroid malignancies, for majority of nodules in thyroid, it's FNAC. It's FNAC. So here, what is the correct answer? D option is incorrect. That FNAC is not useful for diagnosis. Okay. Now guys, question for all of you. Tell me 3 conditions which are limitations of FNAC. Means FNAC cannot make the diagnosis of these 3 conditions. Here you need biopsy. Tell me in the comment box. Conditions where FNAC cannot make the diagnosis. Diagnosis is made by biopsy. Tell me in the comment box. I'm waiting. Dr. Naruto, follicular adenoma carcinoma. Very good. Follicular adenoma carcinoma. I'm talking about thyroid disorders. Thyroid disorder. One is follicular adenoma carcinoma. Second guys, second. Yes. Now let me tell you what are the limitations of FNAC. Guys, you have to remember limitations of FNAC. So first, it cannot differentiate follicular adenoma from follicular carcinoma. Follicular adenoma from follicular carcinoma. All of you know why? Why it cannot differentiate? Because, yes, because in follicular carcinoma there is vascular invasion and capsular invasion. And this vascular invasion and capsular invasion, it is seen on biopsy. Second, Riedl's thyroiditis. So second limitation, Riedl's thyroiditis. Clear? What is the problem in Riedl's thyroiditis? It is invasive fibrous thyroiditis. So whole thyroid as well as parathyroid, it's completely replaced by fibrous tissue. That's why you need biopsy. And third condition, thyroid lymphoma. In thyroid lymphoma also, investigation of choice for diagnosis, it's biopsy. So in all these cases, what you require? You require biopsy in all these cases. Clear guys? You require what? Biopsy. So let me tell you, lymphoma anywhere in the body, investigation of choice is biopsy. Why? Because we have to put lots of markers. So you need adequate chunk of tissue. So anywhere in the body, if lymphoma is there, investigation of choice for diagnosis, biopsy. These are the 3 limitations of FNAC. Next question guys, tell me this question. Which of the following radioisotope is used in carcinoma thyroid? Tell me guys, radioisotope used in carcinoma thyroid. Naruto, Rohit, Karina, Smith, Nikhisha, Mohit, Ankit, Nisi, Ajhar, Akshit, Ashfaq, Mehak, Hitesh, Mithu, Disha, Parveen, Sandesh, everybody is correct. So you know 2 commonly used radioisotopes. One is iodine 123. Can you tell me the half-life? Guys, half-life 131, 123, 13 hours. 131, 8 days. 8 days. So what is the use of iodine 123? Since the half-life is shorter, that's why it is used for diagnostic purpose, and we are using it for radioactive iodine scan. Radioactive iodine scan. And iodine 131, here we are using it for radioactive iodine ablation. Radioactive iodine ablation. So for carcinoma thyroid, what to prevent recurrence, especially in follicular and papillary, we are using radioactive iodine ablation. So which one is used? It's the radioactive iodine ablation. For that we are using iodine 131. So correct answer for this question is D. We use iodine 131. So here you can see both 123 and 131 are used to image the thyroid gland. We can use both. But iodine 131, since it's having longer half-life, it is used for radioactive iodine ablation. Clear? So here, this iodine 131, it is used to screen and treat patients with differentiated thyroid cancer for metastatic disease. And you know What are the malignancies which are included in differentiated thyroid cancer? Papillary. It is papillary carcinoma. And what else? Follicular. We include papillary as well as follicular. These are the well differentiated thyroid cancer. Clear, guys? Well differentiated thyroid cancer. Okay, see, some of you are having this kind of problem that you don't have the skills of giving injection or suturing. Let me tell you guys, whenever you will do internship, you will do lots of injection. Yes, you can give injection, you can do the suturing. And whenever you are doing post graduation in some branch, even if it's medicine, even if it's surgery, you are supposed to do lots of basic interventions. So don't have this kind of thing. You have to clear the exam. This should be your first priority. The skills can be learned by a non-medico. You have seen people who are not even MBBS, they learned the skill of giving injection, inserting RT Foleys. Compounders are doing that. Your people are doctors, you can easily learn. So skills, not a big deal. Yes, if you pass the exam, clear the exam, after that you can learn all these skills easily. Even in internship and during post graduation, throughout 3 years, you are doing interventions. So don't worry about that. Next, see this question. A female patient after laparoscopic cholecystectomy presented with cystic duct stump leak, what should be the immediate management? Guys, tell me what is the correct answer. Let me see who is the genius over here. Immediate management. There is immediate management. There is cystic duct stump leak. Yes, Dr. Naruto, Krishna. Two people are correct till now. Two people only. Two people only till now. Krishna, only two people. Krishna Kant. Modi ji is also there. Modi ji. Medico's channel. Karina. Ankit Gujjar. Okay? Okay, guys. Nisi. Let me tell you the concept. It's very easy to understand. Have a look. Imagine this is the patient. This is the liver. This is the gallbladder. This is the bile duct. Clear, guys? Now, lap cholecystectomy was done. Why? Because this patient was having multiple stones. Patient was having multiple stones in the gallbladder. That's why lap chole was done. Whenever you are handling the gallbladder during lap chole, sometimes a stone slips into CBD. Imagine a stone slips into CBD. After that, what you do? You apply the clip. So what you do? You apply the clip, and after applying the clip, you cut the gallbladder and you remove it. So what happened? This gallbladder was removed. Okay, guys? So you can see here, this gallbladder was removed. Now what you are left with? Now you are left with cystic duct stump. Clear? But what will be happening in post-operative period? Since stone is there in the CBD, it is going to increase the pressure. And if it increases the pressure, what will happen? The clips will be dislodged. So what will happen? You can see the clips are dislodged. Still stone is there. Where? The stone is in the CBD. And what happens? Bile is getting leaked from here. So there is bile leak from cystic duct stump. This is known as cystic duct stump leak. Clear, guys? So this patient is having cystic duct stump leak. Why this leak is there? Because there is increased pressure in the CBD. And what is the easiest way to remove this? To remove the stone, to decrease the pressure. So obviously what you do, you go for ERCP. If the stone is there, remove the stone. And if some stricture is there, perform the stenting. So what is the immediate management? ERCP with stenting. Immediately in post-operative period, if this kind of problem is there, because of bile leak, what happens? The bile duct is retracted. So reconstructive surgery should not be done. Only conservative management in cystic duct stump, it's not advised. If there is obstruction, it should be relieved. And you should not go for exploratory laparotomy if the patient can be managed by minimal invasive intervention. Clear, guys? So what is the correct answer here? ERCP with stenting. ERCP with stenting. Clear? So majority of you were correct. Now this question, see, a patient presented with pain where right hypochondrium. Blood investigation showed AST 22, ALT 27, means it's normal. AST serum transaminases are normal. Serum bilirubin, it is raised, it is 5 milligram percent, ALP 200. So what is the problem? Pain in right hypochondrium, patient is having raised bilirubin, means jaundice, ALP is raised. So what should be the initial investigation in this patient? Tell me guys, initial investigation. Sharik Hussain, Neelam, Akshit, Riya, Nisi, Dr. Saab, Dr. VS, Hitesh Singh, Disha, everybody is correct guys, everybody. All of you know, whenever there is any hepatobiliary pancreatic disease, any liver abscess, gallstone, CBD stone, acute pancreatitis, or some problem related to pancreas. So any patient who is having suspected hepatobiliary pancreatic disease, in all these cases, first investigation done is ultrasound. First investigation done in a suspected case of hepatobiliary pancreatic disease, that is ultrasound. So here this patient is having jaundice, this patient is having raised ALP, so first investigation done. First investigation done, that is ultrasound. Tell me, HIDA scan, you know, this is the gold standard investigation. Gold standard investigation for acute cholecystitis. For acute cholecystitis. In which cases we go for CCT if patient is having tumor, carcinoma gallbladder. HCC, in that case we go for triple phase CT. Patient is having carcinoma pancreas. So especially for malignancies of hepatobiliary pancreatic tract. Malignancies of hepatobiliary pancreatic tract like HCC, like carcinoma gallbladder, like carcinoma pancreas. Carcinoma pancreas, okay? Now guys, this is the situation. See, this is the patient. Patient is having pain in right hypochondrium, means most probably this patient will be having stone in gallbladder. Patient is having raised bilirubin, ALP is raised, means patient is having stone in CBD. So one question is for all of you, tell me, what is the investigation of choice for diagnosis of CBD stone? Guys, tell me. In comment box, investigation of choice for diagnosis of CBD stone. Investigation of choice. Yes? Investigation of choice for diagnosis of CBD stone. Tell me. No. No, it's not ultrasound, it's not ERCP. Investigation of choice. Let me see who's going to reply first. Neelam, Sirvi, first person to reply. Neelam, majority of times you are correct. Very good. Your preparation is up to the mark. Majority of times you are correct. Krishna Kant, 2 people only. See, investigation of choice for CBD stone, it is MRCP, and the gold standard, it is ERCP. Why? Because ERCP is diagnostic and therapeutic. Clear guys? Now this question. Easy question. Chronic liver disease patient presented to OPD with pain and tenderness all over abdomen. Ascitic fluid examination revealed neutrophils. How much? 500 per mm cube. What is the next best step? First, you guys tell me what's the diagnosis. This patient is having pain and tenderness all over abdomen. Ascites is also there. It means there is peritonitis. Guys, tell me which type of peritonitis. Very good. Neelam, Akshit, Naruto, Suhas, Karina, Krishnakant, Narendra Modi ji, Medico's channel, Kamlesh, Shweta, everybody is correct. Everybody is correct. Guys, everybody, you made the diagnosis. This patient is having spontaneous bacterial peritonitis. What is the problem in spontaneous bacterial peritonitis? There should be ascites. What is the most common cause of ascites in adults? Chronic liver disease or cirrhosis. And what is the most common cause of ascites in children? You know, nephrotic syndrome. There is nephrotic syndrome. So what happens in this case? There is bacterial translocation from gut to mesenteric lymph node, from mesenteric lymph node to ascitic fluid. So it is monomicrobial. What kind of infection? It's monomicrobial. In adults, overall, what's the most common organism? E. coli. And in children, what is the most common organism? This is group A, streptococci. This is group A, streptococci. Clear? In this case, what is the diagnostic criteria? Whenever we are performing paracentesis, we are sending the specimen, ascitic fluid, there should be neutrophils. How much? Neutrophils more than 250. neutrophils more than 250 per mm cube, and there should be monomicrobial growth. Monomicrobial growth. And what is the treatment? Here we give IV ceftriaxone plus albumin. IV ceftriaxone plus albumin. So what is the correct answer? IV ceftriaxone. Paracentesis not required. Albumin plus midodrine not required. Octreotide no. So correct answer is IV ceftriaxone. Actually it is IV ceftriaxone plus albumin. So correct answer is A. A. Majority of you are correct, guys. Next, tell me what is the correct answer here. Easy question. Okay, so here you can see a chronic alcoholic patient presented to the hospital with history of severe epigastric pain radiating towards left side. Severe epigastric pain radiating towards left side of back. After 10 weeks of recovery, CT was done. Image is given below. What is the diagnosis? Everybody is correct. Everybody. It is pseudocyst. So you can see here, initially, patient was having attack of acute pancreatitis. Epigastric pain radiating to left side of back. Epigastric pain radiating to left side of back. Patient was having attack of acute pancreatitis. There is fluid collection. Usually, after 4 weeks, this fluid collection is walled off by granulation tissue that is known as pseudocyst. So it is false cyst. Pseudocyst, false cyst. So here you can see, in this image you can see, this is the cyst. Clear? And can you tell me what is this organ? You can see this organ. What is this organ? Yes, this organ is stomach. This is stomach. Clear? So this pseudocyst, it is going to compress what? Posterior wall of stomach, and the capacity is reduced. So it is going to cause obstruction. That's why majority of patients are asymptomatic. Why? Because cyst is small. If cyst is sufficiently large, it is going to cause obstruction. So most common symptom, abdominal pain, and patient will be having what? Non-bilious vomiting. Clear, guys? So correct answer for this question. Correct answer for this question. Yes, it is pseudocyst. This is pseudocyst. Now one question for all of you. Tell me, what is the investigation of choice for diagnosis of pseudocyst? Tell me, guys. Investigation of choice for diagnosis of pseudocyst. Tell me. Easy question. Easy question, guys. Investigation of choice. Yes? Waiting for your reply, guys. I'm waiting. Humble doctor, first person. Ria, Mohit, everybody is correct. Obviously, it is CT. It is CCT. So, guys, it is CCT. Now, can you tell me what is the treatment of choice? Treatment of choice for pseudocyst. It is cystojejunostomy. Treatment of choice, that is cystojejunostomy. Clear? And alternative treatment, which is most popular, it is cystogastrostomy. So most popular, that is cystogastrostomy. Treatment of choice is cystojejunostomy. Clear? Next, very easy question. Similar question was asked many times in exam. Okay? So, according to image given below, obtained from stomach of a woman, which specialist is needed along with surgeon. Okay, guys? So, you know, what is this? This is trichobezoar. What is the problem? The patients who are having trichobezoar, they have habit of trichophagia. They eat their own hair. Mainly it is more common in children, especially in females who have long hair. And after that, what will happen? This hair is going to cause outlet obstruction. It is going to cause obstruction. Clear? And after that, what we have to do? We have to perform gastrotomy. So we have to perform gastrotomy. We have to remove the hair ball. But since patient is having psychiatric disorder of eating her own hair, so what you need? You have to refer this patient. So we have to refer this patient to psychiatrist. Refer this patient to psychiatrist. Now simple question. You know the story of Rapunzel. Tell me what's Rapunzel syndrome. Guys, tell me. What's the Rapunzel syndrome? Rapunzel syndrome, it is related to trichobezoar. Tell me, what is this Rapunzel syndrome? Rapunzel. Dhruv Panchal, you tell me. Yes, Dhruv, tell me what is Rapunzel syndrome. Let me see who is going to reply first. Shweta, long hair. Yes, till which organ? Till which organ the hair is reaching? It is reaching till which organ? Yes, if this hair ball, yes, it's the hair ball, it is reaching till which organ? Patient is having trichobezoar, it is reaching, no, organ. When patient is going to eat the hair, whenever the hair reaches duodenum. Clear? So if hair reaches duodenum, it means patient is having Rapunzel syndrome. It's seen in patients of trichobezoar. Okay? Very good. Jejunum. It's duodenum. Right? Now, guys, this question. Patient presented to hospital with hematemesis after binge alcohol drinking and forceful vomiting. What is the cause? Tell me. Let me see who's going to reply this correctly. What is the cause? Majority Smith, Humble Doctor, Karina, Akshit, Naruto, Krishnakant, Gokul, Ruchita, Suhas, Nidhi. Everybody is correct, guys. So patient is having hematemesis after binge drinking. Why not portal hypertension? Portal hypertension is seen in the patients who are having history of chronic liver disease. Long history of drinking will be there. In peptic ulcer disease, there is no relation with binge alcohol drinking. Esophageal varices, obviously it will develop in the patients who are having portal hypertension. So what happens in binge drinking? You can see this is the patient. Whenever after binge drinking, patient is going to vomit. Repeated episodes of vomiting, forceful vomiting, two things can occur. What? If vomiting occurs against closed glottis, there can be tear. And where can be tear? This tear can be in the esophagus. This is actually longitudinal perforation known as Boerhaave syndrome. And whenever this tear is just below G junction, where? At cardia. If tear is just below G junction at cardia, this is Mallory-Weiss syndrome. If it is longitudinal tear, where? In esophagus, this is Boerhaave. This is known as Boerhaave syndrome. Clear? Very easy, guys. And if it is in stomach, just below cardia, just below G junction, that's cardia, this is Mallory-Weiss tear or Mallory-Weiss syndrome. Difference. Boerhaave syndrome, it is full thickness perforation. Mallory-Weiss tear, it's partial tear involving mucosa and submucosa. Here, what is the artery responsible for bleeding? It is left gastric artery. So only in 20% cases, there is massive bleeding. Clear? And that's why patient will be having hematemesis. So what is the correct answer? Correct answer for this question. Correct answer, it is Mallory-Weiss syndrome. Guys, it's Mallory-Weiss syndrome. Clear? Or Mallory-Weiss tear. Next question. Easy question. Guys, tell me what is the correct answer. You can make the diagnosis on the basis of history also. 54 years old female. History of low grade fever, weight loss for last 6 months. Barium study, image is given. What is the most probable diagnosis? See the barium study. For the hint, I'm going to tell you what is this organ. This is cecum. This is for the hint. So guys, tell me what's the diagnosis? Yes, very good. Pradeep, Deepa, Insha Mir, Ashfaq, Parveen, Parma, Dhruv, Panchal, Nirmala, Riya, Suhas, Pradeep Yadav, Shiv, Singh, Shekhawat, everybody is correct. This patient is having low grade fever, weight loss. Yes, these are the pointers towards tuberculosis. And what you can see, cecum is reaching up to the right hypochondrium. Cecum is reaching up to this area, right hypochondrium. It means there is pulled up cecum. Simultaneously, you can find the stricture in ileum. So pulled up cecum, this part of ileum is not visible. Stricture in ileum, it is characteristic feature of what? Ileocecal tuberculosis. So this is a classical case of ileocecal tuberculosis. Okay. Now one question for all of you. If I perform barium enema, what kind of appearance will be seen in carcinoma colon? Tell me, guys. What kind of appearance will be seen in carcinoma colon? All of you know. What? Apple core appearance. There is apple core appearance. And if you perform Bayer minima, what kind of appearance in ulcerative colitis? Pipe stem colon. There is ahostral colon, also known as pipe stem colon. Loss of hostrations, so ahostral colon. Clear? Very good. Everybody is correct. Lead pipe. Clear? So these appearances are seen in ulcerative colitis. Okay, guys? So correct answer for this question, it is A. Now see this question. Tell me what is the correct answer. Very easy question. Female patient presented to hospital with complaints of vomiting, diarrhea, wheezing, flushing, palpitations. First you tell me these symptoms suggest what? Vomiting, diarrhea, wheezing, flushing, palpitations. These symptoms are suggestive of what? Yes, carcinoid syndrome. Very good. This is suggestive of what? Patient is having carcinoid syndrome. Most common manifestation of carcinoid syndrome, it is flushing. Others are wheezing, vomiting, diarrhea, palpitations. On laboratory evaluation, you can see high serotonin was found. What is the diagnosis? So obviously it's carcinoid syndrome. You know, carcinoid tumors are going to secrete 5-hydroxytryptamine, which is also known as serotonin. Okay, guys. Now tell me which enzyme is going to catabolize 5-hydroxytryptamine. Simple question for all of you. Which enzyme is going to catabolize 5-hydroxytryptamine? Tell me. Tell me which enzyme? No, I'm not asking end product. Enzyme. It is catabolized by MAO. Can you tell me the full form? Monoamine oxidase. MAO. You know, this enzyme MAO, it is present in three organs LLB. What? Liver, lungs and brain. It is present in liver, lungs and brain. And then it is converted into 5-hydroxyindole acetic acid. And you know, this is excreted in urine. That's why in patients of carcinoid tumor, investigation of choice is what? 24 hours assessment of 5 urinary assessment of or estimation of 5-hydroxyindole acetic acid. Simple. Any patient in whom the production capacity of 5-hydroxytryptamine it exceeds the metabolic capacity. In that case, what will happen? In that case, there will be overload of serotonin, and this is known as carcinoid syndrome. So this is known as carcinoid syndrome. Correct answer is D. Now guys, tell me what is the correct answer here. It's easiest question. This is easiest question. Appearance on barium enema is seen in. Easiest. Everybody is correct. Everybody is correct. Okay, guys. Now, can you tell me what is the name of this appearance? Tell me the name. What is the name of this appearance? Tell me what is the name of this appearance? Shweta Singh. Very good, Shweta. It is sawtooth appearance. So, what's the name of this appearance? You can see here, guys. This is known as sawtooth. This is sawtooth appearance. And you know, sawtooth appearance, it is seen in colonic diverticulosis. This is seen in colonic diverticulosis. And for colonic diverticulosis, what is the investigation of choice? It is barium enema. It is barium enema. That is the investigation of choice. Now, one question is for all of you. Tell me, what is the investigation of choice for diverticulitis? Guys, tell me. Investigation of choice for diagnosis of diverticulitis. Diverticulosis, barium enema. Diverticulitis. Suhas, first person to reply. Suhas. Very good, Suhas. Rohit Pawar. Nikisha. Deepak Raja. Now, rest of you are also correct. It is CCT. So, for diverticulitis. For diverticulitis, investigation of choice for diagnosis, that is CCT. Guys, it is CCT. Clear? Now, next question. A male infant brought with urinary retention was found to have bilateral hydronephrosis. There was history of recurrent urinary tract infection. What is the probable diagnosis? What is the probable diagnosis? Tell me. If patient is having bilateral hydronephrosis, it means yes, the obstruction should be at the level of bladder. The obstruction should be at the level of bladder. Majority of you are correct, guys. Future doctor Nisi, Insa, Mehak, Ashfaq, Akshit Dua, everybody is correct. It is posterior urethral valve. Have a look. See, guys, this is kidney, this is ureter, this is bladder, this is urethra. Okay? What is the problem in posterior urethral valve? You can see there is unidirectional valve. Since there is unidirectional valve, what happens? There is obstruction to the flow of urine. But if you are going to insert the catheter, you can easily insert the catheter. Here is the level of obstruction at or just below verumontanum. That's why, because of this obstruction, there will be back pressure changes. So what? There will be bilateral hydrouretronephrosis, and all of you know bladder will be distended or collapsed. Bladder will be distended. Because of this obstruction, there is VUR, vesico-ureteric reflux, and patient will be having a recurrent infection. Clear? So what is the correct answer? Posterior urethral valve. Why not PUJ obstruction? It is unilateral. More common on left side. So there will be unilateral hydronephrosis. In horseshoe kidney, what happens? In horseshoe kidney, there is no urinary retention. This patient is having urinary retention. Retrocaval ureter, it is more common on right side. So it leads to unilateral hydronephrosis, no urinary retention. So what is the correct answer, guys? Correct answer for this question, it's B. B. Shweta Singh wants to say that, sir, keyhole appearance. Yes, at 28 weeks, especially whenever you are performing ultrasound, on ultrasound, distended bladder appears like this. The distended bladder appears like this, and this is known as what? Keyhole sign. So there is keyhole sign in posterior urethral valve. Okay, guys, now see this question. After alcohol consumption, patient went to bathroom and slipped. Developed pain in suprapubic region. On examination, there was abdominal distension. Guys, there is abdominal distension without suprapubic bulge. Means now the urine is in a peritoneal cavity. Heart rate, BP was normal. What is the most probable diagnosis? Tell me, guys. Smith, Naurang, Shweta, Mukesh, Javed Ansari, Karina, Sharik, Ashfaq, Dr. D.D. Upadhyay, Hassan, Insha Mir, Suhas, Navrang Chaudhary, everybody, Krishnakant, future Dr. Roop Shri, all of you are correct, guys. So you know, bladder rupture is of two types. It is extraperitoneal and intraperitoneal. Tell me, guys, which one is more common? You can see here. Bladder, it is located in pelvis. That's why which fracture is responsible for bladder rupture? Pelvic fracture. And which kind of bladder rupture? This is extraperitoneal. Whenever this bladder is distended, and when the bladder is distended, then some kind of trauma is going to occur. What will happen? Now the urine will go into peritoneal cavity. So patient will be having suprapubic pain, difficulty in passing urine, hematuria, plus since urine enters into peritoneal cavity, patient will be having peritonitis. Patient will be having peritonitis. This is known as intraperitoneal bladder rupture, though it is less common. In this case, what happens? There is intraperitoneal bladder rupture. Why? Because there is abdominal distension. Correct answer is A. Not extraperitoneal. Why not urethral injury? Because in urethral injury, the bladder is palpable. Clear? There is no urinary retention. Why? Because you can see there is no suprapubic bulge. That's why there is no urinary retention. So correct answer for this question is A. Now simple question guys, see this question and tell me the correct answer. Easiest. 50 years old patient felt heaviness in left scrotum. He was suspecting cancer, so came to emergency. There was no pain, tenderness, transillumination, negative, most likely diagnosis. Painless condition, heaviness in left scrotum, transillumination, negative, most likely diagnosis. Didi, Nidhi, Naruto, Nikhisha, Sharik, Shweta, Suhas, Deepak Raja, Love Pandey, Mukesh, everybody is correct. So guys, it's a classical case of varicocele. Because varicocele is painless, transillumination it's negative. Acute epididymoarchitis, what happens? This patient is having pain and tenderness. In this patient, there is pain and tenderness. Clear guys? In vaginal hydrocele, transillumination it is negative, positive. So positive transillumination. Transillumination, that's positive. Varicocele, it's the correct answer. And you know, testicular torsion is very painful. There is severe agonizing pain. It's very painful. There is severe agonizing pain. So correct answer varicocele. And all of you know that varicocele is more common on which side? Left side. Clear guys? Correct answer is C. It is more common on left side. Now another question, very easy. Tell me what is the correct answer. 50 years old female underwent total hip replacement after fracture neck of femur. She was immobilized for 3 months. Suddenly developed breathlessness, brought to the emergency. Most likely cause. Most likely cause. Yes, very good. Majority is marking fat embolism. Suhas, Gungo, Mithu Kumar, Medico's channel, Mukesh, Riya, Nidhi Kashyap, Jaideep Jain. Guys, duration is very important. Let me give you the history. Imagine a patient is having road traffic accident and this patient is having long bone fracture. Road traffic accident, patient is having long bone fracture. Patient is brought to the emergency. Patient is all right, appears all right, but after 24 to 48 hours maximum, after 48 hours maximum, usually within 24 to 48 hours, this patient develops breathlessness. This patient develops altered sensorium, confusion, and there is petechiae or purpura in axilla, chest, subconjunctival fold, retina. Duration within 48 hours. Here you can see the patient is immobilized for 3 months. If patient is immobilized for long duration of time, obviously patient developed DVT. And because of this deep venous thrombosis, what happened? Pulmonary embolism. So this is what kind of embolism? This is venous thromboembolism. This is not the air embolism, systemic embolism or fat embolism. Clear? We discussed. So this is a classical case of venous thromboembolism. Let me tell you, if you see around your colony, in your surroundings, among your relatives, the females who are postmenopausal, age 50 to 60, when they slips in washroom, generally there is fracture neck of femur. We perform hip replacement. You can't believe patient is immobilized for long duration of time. Family members are going to ignore the patient, and usually within 2 to 3 months there is DVT, pulmonary embolism, and sometimes patient expires. This is the classical history. You can find lots of example among your colony, in the surrounding. So correct answer is A. Now guys, tell me here what's the correct answer. Elderly male presented to hospital with lumbar pain and ballotable mass in lumbar region. Lumbar pain, ballotable mass means it's kidney. During inspiration, there is lassitude. On examination, laboratory investigation, RBCs were present in the urine without any pus cells, means patient is having hematuria. What's the most probable cause? Now can you see guys, what's the problem here? There is mass, there is pain, there is hematuria. Mass pain, hematuria. Tell me the diagnosis. Mass pain, hematuria. Javed, Nirmala, Kamlesh, Noor Alam, Love Pandey, Shweta, Gungo, Nishi, Chandan, Keshwani. Very good. So this triad, it is seen in RCC. Guys, tell me, what is the name of this triad? Question for all of you. Name of this triad. What is the name of this triad? Guys, easy question. It is seen only in 10% patients. 10% patients of RCC having advanced disease. Tell me the name of this triad. Only 10% patients having advanced disease. Tell me. Too late. First person to reply, Nikisha. Nikisha. Very good, Nikisha. It's too late triad. What's the name? This is too late. So the name of this triad, this is too late triad. Okay. Another question for all of you. Out of mass pain, hematuria, which one is the most common symptom? Tell me, guys. Out of mass pain, hematuria, which one is the most common symptom? Chandni, you are correct. Most common symptom. Mass pain, hematuria, what is the most common symptom? Nikisha, correct. Nikisha, very good. Majority of times you are correct. It's hematuria. Suhas, very good. It's not mass, guys. It's hematuria. This is the most common symptom. Clear? Now, rule out. In polycystic kidney disease, what happens? Palatable mass, lumbar pain, hematuria. Clear? This combination is not there. In polycystic kidney disease, there might be the mass. Clear? But usually, lumbar pain is not there. Hematuria is there. It's gross sometimes. Clear? Hydronephrosis. If there is hydronephrosis, what happens? In hydronephrosis, there will be evidence of obstruction. And what else? There will be infection. So pus cells are not there, so no evidence of infection. In polycystic kidney disease also, what happens? There is increased risk of infection. Correct answer is RCC. Chronic pyelonephritis. In this case, palatable mass is not there. And there will be evidence of infection. So correct answer for this question is C. Again, very easy question, guys. Let me see who is going to reply this question correctly. 60 years old male presented to the hospital with low back pain and sclerotic lesion in vertebra. What do you mean by sclerotic lesion in vertebra? This is known as osteoblastic secondaries. Sclerotic means this is known as osteoblastic secondaries. Now it's very, very easy. Low back pain, osteoblastic secondaries, Ajitesh Mohanty, Mithu Kumar, very good, Kamlesh, Ashfaq, D.D. Upadhyay, Noor Alam, Ruchika, Nirmala. Yes, everybody is correct, guys. It's a classical case of male patient. Back pain, osteoblastic secondaries. It's a classical case of CA prostate. Because you know, most common malignancy in males responsible for bone metastasis, CA prostate, and it leads to osteoblastic secondaries. So correct answer is A. In tuberculosis also back pain can be there, but not the sclerotic lesion. In RCC, there is pulsatile secondaries. What kind of secondaries? Pulsatile. It is osteolytic and hypervascular. And most common site of metastasis, it is lungs. In carcinoma colon, most common site of metastasis, it is liver. So correct answer A. This is carcinoma prostate. Guys, this is carcinoma prostate. Okay. Next question. Which of the following is most appropriate treatment for the given condition? First, you tell me what is the diagnosis? What is the diagnosis here? Everybody is correct. This is the famous question of FMG. Almost every year, same image is asked, same question is asked. Guys, what is the diagnosis? Dermoid. Which dermoid? Yes, it's dermoid. Which dermoid? Tell me, guys, which dermoid? Javed, which dermoid? Let me see who's going to reply correctly. Which dermoid? This is dermoid. Which dermoid? Nobody replied yet. Which dermoid? First person, Muskan Jain. Muskan Jain, first person to reply correctly. This is angular dermoid in relation to outer angle of eye near eyebrow. Near eyebrow. So this is angular dermoid. And you know, in angular dermoid, what is the treatment? The treatment is surgical excision. So guys, we go for surgical excision. This is angular dermoid. Clear? Correct answer for this question is D. Sclerotherapy, IND, radiotherapy, these are not having any role. For angular dermoid, we go for surgical excision. Clear? We go for surgical excision. Next question, very easy. Tell me what is the correct answer. Guys, patient of RTA, road traffic accident, brought to the emergency with BP 80/60. MMHG fast was positive, fluid resuscitation was done, but patient was not improving. Next best step. If systolic blood pressure is less than 100, it means patient is unstable. This patient is unstable, fast is positive, it means there is bleeding. Evidence of bleeding is there. Patient is having hypotension. So you have given the fluid, but still patient is not improving. What is the correct answer here, guys? Everybody is correct. Ajitesh, Nirmala, Sandeep, Pradeep, Rajkumar, Varun Kashyap, DD Upadhyay, everybody is correct. What? It is exploratory laparotomy. You know, any patient of blunt trauma abdomen brought to the emergency, what is first investigation? The first investigation done, that is fast. And what is the gold standard investigation? Important point. If patient is stable. For stable patient, the gold standard investigation, that is CCT. Here patient is unstable. We resuscitated the patient, gave the fluid, still patient is not improving, means there must be some ongoing bleeding. And in that case, what you have to go for? Exploratory laparotomy. So when fast is positive, patient is unstable, important point. Fast is positive and the patient is unstable. Unstable, we perform exploratory laparotomy. Fast is positive, patient is stable, then confirm the findings by CCT. In that case, we confirm the findings by CCT. So correct answer for this question is D. It is D. After that, very, very easy question, guys. Tell me what is the correct answer here. Yes. Type of bladder cancer seen in patient with history of working with dye related industry. Dye related industry. Very good. Nirmala, Kamlesh, Nikisha, Naruto, Karina, Nandi, Dua, Dr. Shweta, Jishan, everybody is correct. You know, printing industry, dyeing industry. Which dye is aniline? If there is exposure of aniline dyes, sometimes there is exposure of acrolein. Aniline dyes, acrolein. Clear? So there is exposure in printing industry, dyeing industry like Bombay Dyeing, Hindustan Times, newspaper industry, Times of India. In these cases, if a patient is smoker also, smoking further increases the risk. So it's a risk factor for which malignancy? Transitional cell carcinoma. And all of you know that transitional cell carcinoma is the most common type of CA bladder. Most common type of carcinoma bladder. Transitional cell carcinoma associated with smoking, printing, dyeing, industries. There is increased risk. Okay, so correct answer for this question, it is C. Now guys, tell me what is the correct answer here. A newborn male baby. Mother found empty scrotum. On examination, left testis is in inguinal region, right testis is in perineum. Which of the following is correct? Tell me. Tell me which one is correct. Kamlesh, Naruto, Suhas, Shiv, Chandni, Nidhi, Nirmala, Karina, Washim, Ruchika, Ajitesh, Chetan, Disha. Everybody is correct. Now see, guys, it's very, very easy to understand. Have a look. This is the abdomen. Okay, you know that testis develops from posterior abdominal wall, and after that it goes into scrotum. This is deep ring. So how testis descends? It goes to the deep ring, follows the inguinal canal, superficial ring, and then goes to the scrotum. So sometimes whenever testis is not in the scrotum, but it is present along the line of descent. Along the line means near deep ring, in the inguinal canal, near superficial ring. So if it is located along the line of descent, this is known as undescended. And if it is located outside the line of descent, anywhere in the perineum, but not along the line of descent, that is ectopic. So what you have seen here, the left testis is in inguinal region, it means left testis, this is undescended. Right testis is in perineum, it means it is outside the location of normal descent, so this is ectopic. So what is the correct answer? Correct answer for this question, left is undescended, right is ectopic. Similar questions were asked many times in exam, and you must be knowing what is the best age for orchidopexy in undescended testis? 6 months, and it should not be delayed by 12 months. So best age, it is 6 months, guys, and it should not be delayed by 12 months. So important point, in undescended testis, best age for orchidopexy, this is 6 months, and it should not be delayed by 12 months. Clear? Next question, very easy. Here you can see, whenever patient is having ectopic testis, it lies outside the normal line of descent. Okay, easy question, guys. Tell me what is the correct answer here. Young male underwent lumbar sympathectomy. Bilateral L1 ganglions were removed. Most common side effect. Tell me. Most common side effect. Ashish, Chandni, Nidhi, Smith, Akshit, Alok, Mukesh, Mohit, Kamlesh, Karina, Naruto, Dide, Ajit, Devranjas, Lavanshi, Ashfaq, Nishi, Mehak, everybody is correct. So guys, first you tell me for which condition we are performing lumbar sympathectomy. Usually lumbar sympathectomy, it is performed for rest pain. Which patients? Patients of Burgess disease. So patients of Burgess disease who are having rest pain. Burgess disease patient who are having rest pain. Okay. Now there is L1 to L5 sympathetic ganglia on one side, which is going to supply the lower limb. So whenever we are planning lumbar sympathectomy, usually you are going to remove L1 to L4. Clear? L1 to L4 sympathetic ganglia is removed. What problem? Whenever we are planning bilateral lumbar sympathectomy, in that case, at least L1 should be preserved on one side. Why L1 should be preserved on one side? You can see here. This is bladder. This is prostate. This is urethra. Clear? This is testis. This is ejaculatory duct. Now here there is internal sphincter. This internal sphincter is smooth muscle. It is under control of L1. So if bilaterally L1 is removed, you know that erection is because of parasympathetic system and ejaculation is because of sympathetic system. So if you are going to remove bilateral L1, what will happen? This sphincter will not be closed at the time of ejaculation. So at the time of ejaculation, if sphincter is not closed, some amount of semen will also enter into the bladder. And when semen enters into the bladder, this is known as retrograde ejaculation. This retrograde ejaculation is also seen after TURP when this internal sphincter is injured. It is also seen whenever we are giving alpha blockers. Why? Because alpha blockers are going to relax the smooth muscle, and this sphincter is smooth muscle. I'm repeating. So retrograde ejaculation, it is seen when bilateral L1 ganglia is removed. In TURP, you are going to injure internal sphincter. or you are giving alpha blockers which are smooth muscle relaxant, and this sphincter is a smooth muscle, it relaxes. So what happens? Patient will be having retrograde ejaculation. Clear? That's the problem. That's why whenever we are performing bilateral lumbar sympathectomy, at least L1 should be preserved on one side. L1 should be preserved on one side. Clear, guys? So correct answer is retrograde ejaculation. Now read this question. Very, very easy. Tell me what is the correct answer. Patient with old burn scar develops symptoms over burnt area indicative of malignancy. Tell me what is the name of this ulcer. Guys, first tell me what is the name of this ulcer. Burn scar. Which ulcer? First you tell me which ulcer. Let me see who is going to reply correctly. First person. Nikisha Jacob. Most of the times Nikisha you are correct. Medico's channel. Nirmala. Very good. Chetan. It's Marjolin's ulcer. Guys, it's Marjolin's. Clear? And you know this Marjolin's ulcer, it is low grade squamous cell carcinoma. What's the problem? It is low grade squamous cell carcinoma. Important point. Since Marjolin's ulcer is arising from scar, in scar there is only fibrous tissue. Vessels are damaged, lymphatics are damaged, nerves are damaged. So tell me, it is painful or painless? Nerves are damaged, painless. Vessels are damaged, it is hypervascular or relatively avascular? Avascular. Rapid growth or slow growth? Slow growth. Lymph node metastasis is seen or not seen? Not seen. Why? Because lymphatics are injured or damaged. So correct answer, this patient is having squamous cell carcinoma. This is Marjolin's ulcer. Patient is having squamous cell carcinoma. It is relatively avascular, painless, slow growth without any lymph node metastasis. Okay guys, now tell me what is the diagnosis here. What is the diagnosis based on the given image? Easy question. See the appearance. This tumor is classical. Can you see there is pearly white nodules in the periphery and there is central umbilication or depression? There is central umbilication or depression with pearly white nodules in the periphery. Tell me what is this? So let me check. Rolled edges. Very good. Chandni, Nirmala, Deepak Raja, S. Khan, Shiv, Suhas, Ruchika Trivedi, Riya, Sandesh, Mukesh Kumar, Muskan. Majority of you are correct, guys. So can you see here? There is central umbilication or depression with pearly white nodules in periphery. This is classical type of basal cell carcinoma. And what is that classical type? It is nodular. The most common type, it's nodular. So this is what? Nodular variety. So it is a classical case of basal cell carcinoma and it is more common in fair skinned people. In fair skinned people, this is more common. Ideally, this area is not the most common site. The most common site is nose and inner canthus. So it is mainly seen in which area? You can see here. You join this ear lobule to the corner of mouth. So in this region it is seen. This is also known as tear cancer. What is the other name? This is also known as tear cancer. So in this region it is seen. Clear? So what is the correct answer? This patient is having basal cell carcinoma and we discussed what is the most common variety. It is nodular variety. What is the other name of basal cell carcinoma? Also known as rodent ulcer. This is also known as rodent ulcer. Clear, guys? So correct answer for this question is A. It is A. Obviously, since the name is basal cell carcinoma, it is arising from which layer? Basal layer. It arises from basal layer. Every year there is one question related to Glasgow Coma Scale, GCS. Clear? So calculate What is the GCS here? Let me see who is the fastest. Who is the fastest person? Man opens eyes to pain, speaking inappropriate words, and there is withdrawal to pain. What is the GCS? Fastest: Ajitesh Mohanty, Deepak Raja, Chandani Keshwani, Kareena, Love Pandey, Kamlesh, yes, S. Khan, Mohit, Lalit, Nikisha, Mithu, everybody is correct. Majority of you are correct, guys. So you know, whenever patient is opening eyes to pain, it is E2. There is speaking inappropriate words, V3. And whenever there is withdrawal to pain, it is M4. So the score is 9. Score is 9. Correct answer is B. Okay. Since it's important, so how to remember GCS is very, very easy. Very easy to remember GCS because there is a mnemonic. Okay, guys. So see how to remember. Okay. See. Obviously, how to remember electronic voting machine, EVM. So there is eye opening, verbal response, best motor response. So first question, out of eye opening, verbal response, best motor response, which one is best predictor of survival? Tell me, guys. Out of these three, which one is best predictor of survival? Everything is written, guys. Best predictor of survival. Yes, motor response. So guys, first question, this one is the best predictor of survival. This is best predictor. Best predictor. Okay, it is easy to remember this eye opening. If it's spontaneous, score is 4. To speech or to command, it is 3. To pain or pressure, it is 2. And no response, 1. Spontaneous, 4. To speech or to command, 3. On pain or pressure, 2. No response, 1. Verbal response, if patient is oriented, it is 5. Confused, 4. Words, 3. If patient is producing only sounds, 2. No response, 1. Now how to remember the verbal response? Mnemonic is one confused word. Mnemonic, one confused word sounds nowhere. It sounds nowhere. Clear? So 1, oriented, this is 5. Confused, this is 4. Word, 3. Sounds, 2. No response, 1. Now best motor response, if patient is obeying command, it is 6. Patient is localizing pain or patient is localizing, it is 5. There is normal flexion or withdrawal to pain, that is 4. Withdrawal to pain. There is abnormal flexion, 3. Extension, 2. No response, 1. So how to remember this one? See, obey localities. How to remember? Obey localities with flexion and extension. With flexion and extension. So obey localities with flexion and extension. Clear? So obey commands, 6. Locality means localizes pain, 5. With means withdrawal to pain, 4. Flexion, if there is flexion, withdrawal to pain, abnormal flexion, that is 3. If there is extension, 2. And if there is no response, you know that no response is 1. So one confused word sounds nowhere, and the second is obey localities with flexion and extension. Clear, guys? This is very, very important. Almost every year there is one question related to GCS. So you have to remember GCS. Okay? Now next easy question. A 17-year-old male brought to the hospital with recurrent attacks of intussusception. During surgery, multiple polyps found in small intestine. One of the polyp was removed, whose histopathological image is given below. What is the pathological change shown in the picture? Okay, so guys, this patient is having recurrent attacks of intussusception. Why? Because of multiple polyps. Clear? Tell me which syndrome patient is suffering from. Everybody is correct. Shiv, Ashfaq, Suhas, Krishnakant, Ajitesh, tell me the syndrome patient is suffering from. Nisi, syndrome patient is suffering from. Peutz-Jeghers, Suhas, first person, Sandesh, second. So this patient is having Peutz-Jeghers syndrome. And you know, in Peutz-Jeghers syndrome, where is the polyp? S means small intestine, and in small intestine, it is J, jejunum. Because of these polyps, patient is having recurrent intussusception. What kind of polyps are seen in Peutz-Jeghers syndrome? Hamartomatous polyp. And these hamartomatous polyps are having characteristic features. So the patients are having what? Hamartomatous polyps. Clear, guys? So patient is having hamartomatous polyp. Now this hamartomatous polyp, it is having characteristic feature, and what? Two features are there. One is arborization, means branching. Just like there is branching in the tree, you can see this polyp. It looks like that there is branching in the tree. So this is arborization, and there is a second change, pseudo-invasion. So there is arborization, and what else? There is pseudo-invasion. Clear? So what is the correct answer? This is hamartomatous polyp. It is hamartomatous polyp, and it is seen in which patients? Patients who are having Peutz-Jeghers syndrome. Clear, guys? It's Peutz-Jeghers syndrome. Now, next question. What is the correct answer here, guys? Tell me. Male patient presents to hospital with abdominal pain and incidentally detected abdominal aortic aneurysm. What is the appropriate management of this patient? Tell me. Appropriate management. Yes. Nikisha Jacob, very good. Very good, Nikisha. Only one person is correct till now. Nikisha, only one person. Nikisha. Chetan Kumar, second person. Chetan Kumar, very good. Mithu Kumar. Mithu Kumar, yes. Lalit, Suhas, Krishnakant, Deepak Raja, Sharik, Satyadharm, Vasta, Navrang. Now everybody is correct. What is the problem here, guys? Patient is having abdominal aortic aneurysm. First question, what is the most common and most fatal complication of aortic aneurysm? The most common and most fatal complication, it's rupture. Okay, risk of rupture, it is directly proportional to size, that is width or diameter. Width or diameter, see, this is the aneurysm. Clear? So this is the width or diameter. So risk of rupture is directly proportional to size, that is width or diameter. Where is the rupture? There is retroperitoneal, because aorta is located in retroperitoneum. That's why here you can see this is inferior vena cava. So that's why it is going to rupture on left side. So it is retroperitoneal rupture on which side? Left side. Clear? So that's why any patient in whom we are going to detect what? Aortic aneurysm, we have to follow the aortic aneurysm till aneurysm reaches the cutoff size, which is an indication for surgery. So what is that cutoff diameter, which is an indication for surgery? 5.5 centimeter. In patients of aortic aneurysm, abdominal aortic aneurysm, cutoff diameter, it is more than equal to 5.5 centimeter. Clear? So whenever this diameter is achieved, reached, in that case we have to go for elective repair. So see the options, guys, see the options. Immediate surgery, not required. Ultrasound monitoring till the aneurysm reaches 70 mm, no. Monitor till size reaches 40 mm, no. Monitor till size reaches 55 mm or more than equal to 5.5 centimeter. Clear? So for abdominal aortic aneurysm, it is 5.5 centimeter. What is the cutoff diameter for iliac artery? If patient is having iliac artery aneurysm, what is the cutoff diameter? More than equal to 3.5 centimeter. For popliteal artery, for femoral artery, popliteal artery and femoral artery, how much is the cutoff diameter? Cutoff diameter is more than equal to 2. This is more than equal to 2. So you have to remember, this question was asked many times in exam. Correct answer is D. Okay. Next, easy question. Tell me guys, what is the correct answer here? Primary survey of ATLS does not include. Primary survey of ATLS does not include. Most common location of aortic aneurysm. See guys, the most common location of extracranial aneurysm, that is abdominal, that is aortic aneurysm. What is the location? Infrarenal. So most common site of extracranial aneurysm, aortic aneurysm, location is infrarenal. Overall most common site of aneurysm, circle of Willis. So overall most common, circle of Willis. Extracranial most common, abdominal aortic aneurysm. In abdominal aortic aneurysm, most common site, infrarenal. Okay. Okay guys, now tell me. Primary survey of ATLS does not include. Yes, Muskan Jain, very good. Varun, Ajitesh Mohanty, Suhas, D.D. Upadhyay, everybody is correct. Now guys, what is the primary survey? You know, components are A, B, C, D, E. Airway, breathing, circulation, disability, exposure. Clear? Now, in which case we are going for investigation? Whenever circulation, what happens? Here patient might be having hypotension. Hypotension is because of external bleeding, means on the floor or 4 more. So what are those 4 sites of bleeding? Thorax, abdomen, retroperitoneum, and from long bone fractures. Clear? Now how to assess hemothorax? So we can assess hemothorax by chest x-ray. Chest x-ray. How we can assess pelvic fracture which can lead to retroperitoneal hemorrhage? Yes, x-ray pelvis. X-ray pelvis, which view? Chest x-ray PA view, X-ray pelvis AP view. And how you assess abdomen? For assessment of abdomen we perform FAST. Clear? So FAST is used, X-ray, chest X-ray, PA view is used, X-ray pelvis AP view is used, but CT is not the part of primary survey. CT, it is not the part of primary survey. So they ask you what are the 2 most important X-rays? 2 most important X-rays in trauma patient, chest X-ray and pelvic X-ray. So these are 2 most important X-rays. 2 most important X-rays in trauma patient. Clear? Because with pelvic X-ray you detect pelvic fracture, chest X-ray hemothorax, pneumothorax, and by chest X-ray perforation can also be detected. How? Because you can see the free air under right dome of diaphragm. Clear? So correct answer for this question is A, CT scan. Now guys, tell me what is the correct answer here. First see the image. This is the X-ray image. Clear? Now can you see the findings? Okay. Now read the question. 25 years old patient presented with abdominal pain and distension. Abdominal X-ray revealed the below image. Identify the prominent structure seen. So this patient is having small bowel obstruction. Clear? Can you see this? Which bowel is this? What is the characteristic finding? Yes, tell me guys. What you can see in this X-ray? Very good. Hassan, Mithu Kumar, Deepak Raja, Medicos, S. Khan. Yes, very good. So here, what you can see? Valvuli conniventix. Clear? So this is valvuli conniventix. Here you can see there is circumferential ring lag pattern. Can you see guys? These are circumferential ring lag pattern. Valve of Kirk ring. So this is circumferential ring lag pattern. Clear? And this is typical feature of which organ? This is the typical feature of jejunum. That is known as valvuli conniventix. So this is valvuli conniventix. And there is circumferential ring lag pattern. This is characteristic feature of jejunum. So you can see multiple dilated bowel loops placed centrally. Circumferential ring lag pattern, this is jejunum. Ileum, this is featureless or characteristically characterless. So no special feature is there for ileum. And if you see transverse colon, it is having horstrations. Large intestine is wider in caliber, placed peripherally, there is haustration. Clear? So what is the correct answer? Correct answer for this question, C. Okay. Next question, guys, easy question. What is the most common content in hernia englisade? Tell me. Okay, Ashfaq. Ashfaq wants to tell, ask how to differentiate proximal obstruction from distal obstruction. Very easy. Have a look, guys. Very easy. See, this is stomach. This is duodenum. This is jejunum. Clear? And this is what? Ileum. Clear? Here, this is the cecum. This is the appendix. Now, if patient is having proximal small bowel obstruction, that proximal obstruction can be in the duodenum. It can be in the jejunum. So when proximal obstruction will be there, what is more prominent, guys? Vomiting is more prominent. There is colicky pain, non-passage of feces and flatus, but vomiting is more prominent. And if patient is having ileal obstruction, distal obstruction here, the bowel will be distended. So what distension is more prominent? If vomiting is more prominent, dyselectrolytemia is more common. So in proximal obstruction, what? Vomiting is more prominent. And because of vomiting, there is dyselectrolytemia. There is dyselectrolytemia. Clear? If distal obstruction is there, distension is more prominent. Distension. Clear? Second, imagine you can see the jejunum. If you can see this part of jejunum, if you see jejunum is distended, jejunum is visualized, it means obstruction is beyond jejunum. So if jejunum is visible, so obstruction is beyond jejunum, it means it is distal obstruction. And when jejunum is not visible, only proximal part or little part of jejunum is visible, only some part of duodenum is visualized, means little part of bowel in upper abdomen or central abdomen, that is proximal. So whenever, let me tell you the answer also, any question is there related to small bowel obstruction, and if you can see the jejunum, usually it's a distal obstruction. In majority of cases, where is the obstruction? Obstruction is in the ileum. Clear, guys? So sliding hernia, hernia englisade, it is also known as what? Sliding hernia. And in sliding hernia, it is more common on left side. So what is the most common content? Sigmoid colon. Most common content, sigmoid colon. Because it is more common on left side. On right side, what is the content? Cecum. Okay, guys? Cecum is the content on right side. Clear? Overall, most common sigmoid. What is sliding hernia? When the posterior wall of sac is formed by viscera. See? It's like this. This is the anterior wall of sac and this is the bowel. So posterior wall of sac is formed by viscera, that is sliding hernia. Easy question, guys. Tell me what is the correct answer. Lateral internal sphincterotomy. Sphincter is divided. It is useful for, tell me, lateral internal sphincterotomy. Nisi, various types of hernia, it takes time. Clear? So you can watch the lectures because we have recorded lecture over that. Confusion will be clear, don't worry. Lateral sphincterotomy, guys. Lateral sphincterotomy. Tell me what is the correct answer. Yes. D. Mithu Kumar. Mithu Kumar. One person till now. Mithu Kumar replied correctly. Only one person. Mehak, second person. Two people only. Mithu Kumar and Mehak till now. Only two people are correct. Only two. Then Raman Sanoz, Hashan, Dr. RJ, Tanvi Poddar. Let me tell you. Now what happens, guys? Whenever patient is having fissure in ano, there is spasm of internal anal sphincter. So since there is spasm of internal anal sphincter, we give calcium channel blockers. We give nitrates for local application. We inject Botox. But treatment of choice is internal sphincterotomy. So what happens? Circular internal sphincter, it is inner circular layer. So what happens here? We are going to cut certain fibers. So this is Notaras lateral sphincterotomy. So what we perform? We perform Notaras lateral sphincterotomy. And for lateral sphincterotomy, for fissure in ano, we are performing this procedure. So it is done for fissure in ano. What is the treatment for fistula in ano? For fistula in ano, we have fistulotomy, fistulectomy, but mainly we are using seton. Seton or sometimes WAFT. WAFT is video assisted anal fistula treatment for hemorrhoids up to second degree, and some patients of third degree we perform rubber band ligation or sclerotherapy. For selected patients of third degree and fourth degree we perform hemorrhoidectomy. So correct answer for this question, guys, correct answer is D. D is the correct answer. Okay guys, now tell me what is the correct answer here. Which of the following statement is true for Nigro regimen? Guys, tell me what is the correct answer. True for Nigro regimen. Dishant, thank you. Dishant, thank you. Ajitesh, Krishnakant, Nikisha, Tanay Podar, Mithu, Naruto, everybody is correct, guys. So you know Nigro regimen, yes, it is for carcinoma anal canal. And what we give in Nigro regimen, this is chemo radiation. So this is what chemo radiation. So first chemo followed by radiation. And for chemotherapy, what is the agent which we give? We give 5-fluorouracil plus mitomycin C. So first we give chemotherapy followed by radiation, and you can't believe after Nigro regimen majority of tumors disappear, so there is no need for surgery. So see the options, guys. Regimen for anal canal neoplasm incorporates chemotherapy with radiation. It's an alternative to surgery. Advantage of preserving continence. So correct answer is all of the above. So correct answer is all of the above. This is Nigro regimen. Clear, guys? So these were important questions, guys. Since your preparation is so good, because I can see for majority of questions most of you are marking correct answer. Best of luck from the whole team. Keep studying hard, because these 2 weeks, or I should say 14-15 days, are most crucial. Keep studying. Definitely you are going to crack this exam. All the best, guys.